Good day. We are the Group 1 of Section E2, and we're going to be discussing the interdisciplinary approach for the treatment of periodontally compromised malpositioned anterior teeth, a case report. This case is reported by Mikhaela Macariola, Elijah Bacolod, Lyssah Vergara, and Hyacinth Alpuerto.
Introduction. A 61-year-old German Caucasian, systematically healthy, non smoking female presented with the chief complaint of bleeding gums and increasing frontal crowding of the mandibular and maxillary anterior teeth. Initial examination findings showed generalized pocket depths ranging from 4 to 7 mm and gingival recession less than or equal to 2 mm were present throughout the dentition. The occlusal examination revealed angle class 1 molar relationship bilaterally for the first molars and canines. The upper incisors showed pathologic anterior migration and rotations, whereas the lower anterior segment demonstrated anterior crowding with a severely protruded left central incisor. This shows the pre-treatment intraoral photographs. Radiographic examination showed generalized moderate horizontal bone loss in both arches. A diagnosis of moderate to advanced generalized chronic periodontitis with anterior dental crowding was obtained given the information that was provided.
Treatment planning. The treatment planning includes first, the periodontal therapy. This involves the non surgical periodontal therapy such as subgingival instrumentation, oral hygiene instruction, supragingival scaling, and application of biodegradable chlorhexidine chip. Second is the orthodontic treatment. This includes the extraction of mandibular incisor, placement of mini-screw implant in the upper jaw, as well as the application of canine to canine retainers. Third is the periodontal plastic surgery. This involves the correction of gingival margin recession by using an envelope technique and closed by non-resorbable suturing material. And lastly, the restorative treatment. This includes placing of new fixed metal ceramic bridge, gold inlay, and full coverage gold crown. Collaboration. This case report involves the collaboration between periodontal, orthodontic, and restorative approach for the treatment of periodontally compromised patient with maxillary and mandibular anterior crowding. This includes non-surgical periodontal therapy, orthodontic treatment, surgical periodontal treatment, and final restorative treatment, resulting in good and long-term results with regards to periodontal, functional, and aesthetic refinement.
Procedures and techniques. With the patient being diagnosed of moderate to advanced generalized chronic periodontitis with anterior dental crowding, an interdisciplinary approach which include periodontics, orthodontics, and restorative was formulated for the treatment of the patient. Procedures and techniques used in the treatment of the patient are as follows. 1. Patient education in oral hygiene was done, including strict implementation of oral hygiene control and professional tooth cleaning every 4 weeks. 2. For debridement, the periodontist did supragingival scaling and subgingival instrumentation by using the vector ultrasonic system for the removal of subgingival calculus. After a full mouth debridement, application of biodegradable chlorhexidine chip in all periodontal pockets with greater than a 5 millimeter depth were performed for the controlled delivery of chlorhexidine. 4. After periodontal treatment, patient attained good plaque control and clinically healthy gingiva with probing depth of less than 4 millimeters and no sign of bleeding upon probing. The patient was then referred to an orthodontist for the management of malpositioned teeth. 5. Since the patient has mandibular anterior dental crowding, extraction of mandibular left first incisor under local anesthesia was done as a way to attain adequate space for orthodontic treatment. 6. Placement of mini-screw implant in the alveolar bone region was performed in order to gain a stationary anchorage for the distalization of the posterior teeth in the upper jaw. The alignment of the mandibular and maxillary anterior teeth was then improved with the placement of a multi-bracket appliance in both of the upper and lower jaw. 7. The meniscure implant was removed 3 months prior to the removal of the multi-bracket appliances after 24 months of active orthodontic treatment. 8. Maxillary and mandibular teeth were stabilized by application of bonded lingual canine to canine retainers after the removal of the multi-bracket appliances. 9. The patient was then scheduled to visit every 4 weeks for periodontal maintenance during the orthodontic treatment. 10. After 6 months, placement of a connective tissue graft using the envelope technique was done to repair the gingival margin recession seen in the aesthetic area of tooth 41. A picture below shows the clinical situation after orthodontic treatment showing a gingival recession in the aesthetic area of teeth 32 and 41. 11. Connective tissue graft used in the treatment was acquired from the palatal area between the canine and first molar in accordance to the trap door technique. Exposed root surface at the site was then planed using curettes and burrs. 12. The connective tissue was transplanted into a supraperiosteal envelope-like pouch that had been created at the recipient site and was fixed with 2 sutures using non-resorbable number 50 suturing material. 13. Sutures were then removed 1 week after a successful post-operative healing. A picture on the upper right shows the placement of a connective tissue graft employing the envelope technique, whereas a picture on the bottom left shows the clinical situation 10 days post-operative. 14. For the final step in the treatment, restoration with a new fixed metal ceramic bridge replacing the maxillary left second molar as seen on the third photo, insertion of gold inlay on the maxillary right first premolar as seen on the first photo, and a new full coverage gold crown on tooth 47 was incorporated finishing the treatment. Here are photos of the maxillary and mandibular occlusal aspect showing the gold inlays and full coverage gold crown. And here is the post-active treatment panoramic radiograph. Results and outcomes. Periodontal therapy, which included supragingival and subgingival scaling, was the first step in the patient's treatment. Following the treatment, the patient obtained good plaque control and clinically healthy gingiva. The dentition-wide probing depths were less than 4 millimeters compared to the initial probing depths of 4 to 7 millimeters, with no evidence of bleeding upon probing. After attaining good periodontal health, the patient is then referred for orthodontic treatment. The patient present acceptable overjet and overbite with resolved frontal crowding following 24 months of active orthodontic treatment. Periodontal depth and clinical attachment levels were maintained at the normal levels after months of constant periodontal therapy during active orthodontic treatment. Following the transplantation of connective tissue graft using the envelope technique for the reconstruction of the receded gingival margin in the aesthetic area tooth 41. Root coverage was essentially improved with increased width and thickness of keratinized gingival tissue. Overall, stable periodontal health was achieved with combined periodontal and orthodontic therapy, and the elimination of mandibular anterior crowding has improved bone support and provided secure access for effective plaque control. Patient satisfaction and long-term success. Several treatment options have been discussed to the patient with regards to the reconstruction of the aesthetically compromised labial recession. After receiving orthodontic treatment, the patient's main complaint of first mandibular incisors labial recession was successfully corrected by inserting a connective tissue graft using the envelope technique. Furthermore, permanent retention is emphasized in the total treatment plan of the patient. Thus, An application of a long-term lingual bonded wire retention was applied in the upper and lower arch.
Discussion. Periodontal disease can create serious functional and cosmetic issues as well as pathologic migration of the affected teeth. It has been found that approximately 30 to 50% of patients with moderate severe periodontal disease have manifested the signs of pathologic migration of teeth, including rotation, elongation, and spacing or crowding of the incisors. In the case report presented, it was the maxillary and mandibular incisors that showed pathologic and aesthetic concerns. The maxillary incisors presented anterior migrations and rotations, whereas the mandibular incisor showed crowding and a severely protruded 3-1. Since the patient claimed to have no previous crowding, it was believed that the presence of mandibular crowding was due to the pathological migration. Individuals presenting a crowded dental region has been found to accumulate more plaque in crowded areas with more periopathogens compared to an individual without crowding. In this case, with less than 4 millimeters of probing depth and no visible bleeding throughout the dentition, consistent periodontal health was achieved as a result of the combined periodontal and orthodontic treatment. Improving bone stability and securing access for plaque control were made possible by correcting mandibular anterior crowding. With regards to orthodontic treatment, it is more appropriate that periodontally compromised teeth are treated with lighter orthodontic force systems because that can move more easily, and periodontal membrane may be negatively impacted by stronger orthodontic forces. In this case, a titanium mini screw was applied to attain appropriate orthodontic anchorage in the upper left posterior segment. It must be stressed that removing plaque buildup and gingival inflammation is crucial to the orthodontic therapy of adult individuals with periodontal disease. Inadequate oral hygiene instructions and infrequent checkups during orthodontic treatment may result to bone resorption. In this case, initial periodontal conditions were alleviated by scaling and root planing, in combination with a controlled subgingival application of chlorhexidine chip. In addition, strict oral hygiene instructions were implemented including oral hygiene control and professional oral prophylaxis every 4 weeks. However, labial recession and interdental bone loss have resulted after orthodontic treatment, which compromises aesthetic result. This has been successfully corrected by placing a connective tissue graft using the envelope technique. In patients with poor periodontal health, retention planning and the stability of orthodontic treatment need to be given more thought. Hence, for future treatment of the same cases as what was presented in this case, permanent retention is thus frequently included in the overall.
In conclusion, the interdisciplinary treatment approach that involved non-surgical periodontal therapy, orthodontic tooth movement with the use of miniscrew implant for skeletal anchorage, periodontal plastic surgery, and final restorative treatment resulted in significant functional, aesthetic, and periodontal improvements. The comprehensive interdisciplinary approach to this case was well established. In the shared decision making of different specialties, it ensured an accurate diagnosis and an efficient treatment plan. This collaboration was paramount to the case's success. It focused on establishing patient centered care that resulted to optimal outcomes of the diagnosis.
And that would be all for our case report. Thank you and have a good day.